Hello, everyone. Thank you for joining us here at NMAC for our latest Community Spotlight webinar on HIV in the transgender community. We're pleased that you could all join us here today. This is Chip Lewis, Communications Director for NMAC. I'm here with Daniel Pino, Communications Strategist here at NMAC. And we again are pleased to have you here with our special guest topic. We'll start off with a little housekeeping, and I'm going to turn it over to Daniel to deal with some housekeeping issues.
Hello, everybody. Thank you for joining us today. As you can see, the Go-To training has options for you to ask questions and be involved in a webinar so you can get the most out of what's going on in today's presentation. You'll see that there is a chat box feature in which you can raise your hand if you would like to ask a question during the Q&A portion of the site. Additionally, you should know that everyone's audio has been muted by the presenter. That's to make sure that only the presenter is speaking, and that way we can maintain clear conversation with the presentation and also make sure that our audience gets a chance to ask pertinent questions related to the subject matter. If you would like to ask a question immediately for further conversation during the Q&A portion, you can see the chat feature there. You can fill out your question right in that portion, and then you can direct it to either all of the audience or to a specific person. Once you do that, hit send, and your chat box feature will populate with your question during the Q&A portion of the presentation. Of course, this can occur throughout the course of the presentation. You are not limited to ask your questions during the Q&A portion, but we will be referring to questions during the Q&A portion, so we will not be offering immediate feedback unless we are, of course, able to answer the questions in real time.
Thank you, Daniel. Just a couple of other quick housekeeping notifications. If anybody's having audio issues, please let us know in the chat feature. Also, sometimes our internet connection is not as strong as we would like, so some of the slides may stick from time to time. If they do, just give us a second and they will hopefully advance. And if they do not, we will take action to help with that. So it's now my pleasure to introduce our first presenter, Luis Gutierrez-Mock, who is the Project Director for the Triumph Project, a community-led PrEP demonstration project at the Center of Excellence for Transgender Health at UCSF. He has 20 years of experience in transgender HIV prevention and trans health research, 10 of which he has worked at the Center of Excellence for Transgender Health. In his free time, he dances with NMAC Dance Academy, a queer, trans, and allied salsa and bachata dance company in Oakland, California. Luis? Sorry, Luis, 1 second. Luis, your line is open. Please go ahead and start.
Great, thank you so much. Thanks for having me here. I am with the Center of Excellence for Transgender Health at the University of California, San Francisco. And our mission is to increase access to comprehensive, effective, and affirming healthcare services for trans and gender non-binary communities. Next slide, please. We have a number of different programs at the COE. We have a CDC-funded capacity building assistance project. So if you or your organization is wanting to increase your capacity to provide HIV care or HIV prevention services to trans communities, you may request training from us free of charge through our capacity building assistance project. We also have a SHERO's community-based research project, for which I will describe some of those. We are wrapping up the final phase of data analysis for our Transgender Evaluation and Technical Assistance Center, which was a HRSA-funded project with 9 demonstration sites across the United States. We enrolled, I believe, about 830 trans women of color living with HIV into HIV treatment and care across the 9 sites, and we have really incredible data on all of those participants that is in the process of being published right now. We also run the National Transgender HIV Testing Day and the National Transgender Health Summit, which occurs every other year. And the next one is upcoming in April of 2019. Next slide, please. For our community-based research, I'm going to mostly focus today on the Triumph project, which is a PrEP demonstration project, and I'll mostly be talking about PrEP in trans communities. We also have a project called Girlfriends Connect, which is looking at, we enroll trans women who are currently incarcerated in San Francisco County Jail and assist those participants with transitioning out of jail and provide HIV prevention or HIV treatment and care to those participants. Healthy Divas, which is an intervention developed for trans women living with HIV, and then Shiro's, which is a HIV prevention intervention. Next slide, please. So before we really start talking about HIV prevention among trans people, it's important to think about how many trans people there are in the United States, or how many trans people there are. So if we had been talking about this, you know, maybe like 5-6 years ago, we would not have had really good numbers for you, but we do have some great numbers currently. Next slide, please. Of all of the studies that have been done, we find between a 0.1 to 0.6% of individuals who identify as transgender, and you can see that this 0.1% was from the California HIV, or the California LGBT Tobacco Use Survey. And then the Los Angeles County and San Francisco County provided some estimates of the total trans population, and those range from 0.2 to 0.3%. We had the first ever landline survey that was done in Massachusetts in 2012, which was, at the time, that was the best estimate that we had. The researchers from that study called landlines and asked people if they provided a definition of what transgender meant, and asked the individuals who responded on the landlines if they identified as transgender. And this was a population-based study, so we were able to say that in Massachusetts, 0.5% of the population identified as trans. We know that that was likely an undercount because when we're thinking about landlines, not very many people still have landlines. People with landlines generally skew towards older populations. And we also know that younger populations are more likely to identify as trans or gender nonconforming. In 2016, the Williams Institute analyzed the 24 Burfus data and found a 0.6% prevalence of transgender identities. Next slide. And this data analysis is really provided the best national data for sort of the trans population count. So the Behavioral Risk Factor Surveillance System is a state-specific population-based survey that really collects information on a variety of health indicators, and they use both landlines and cell phone lines, so it's not sort of limited to those individuals with landlines. The 2014 Burfus contained an optional module that asked if the respondent was transgender. They provided the definition, and then if so, they asked, you know, kind of like the directionality. So they used slightly outdated terms. So they asked if they were male to female, female to male, or gender nonconforming. Because this was an optional module, not all of the states opted into using it. And so the Behavioral Risk Factor Surveillance System, it's a national population-based survey that all states participate in. But this was a optional module within that. And so only 19 states opted into asking this question. And the Williams Institute used multi-level regression and then also post-stratification to estimate the total trans population for the remaining states, providing us with this 0.6% population estimate for trans people. And then as you can see in here, the states with the highest percentage of trans identified adults were Hawaii, California, and then New Mexico. Washington, D.C. was actually excluded from the analysis because they had such a high percentage of trans people who identified as trans. So 2.8% of individuals within Washington, D.C. identified as transgender. And this is really important because when we're thinking about, you know, the sort of impact of HIV on trans communities, we haven't had a population count. So we have not ever known the denominator in order to estimate the true prevalence. What we've only been able to do is look at the estimated prevalence of HIV or the estimated impact of HIV among trans communities. And this data provides us with much better data, much better way to do some of that data analysis. Unfortunately, the current administration has decided to remove this optional module. So if this is important to you, I would recommend that you contact your local representatives and your state representatives and ask that this module be added back into the BRFIS data. Next slide, please, because this data is really essential to the work that we're doing. So when we're looking at these numbers, again, we're looking at estimated, the sort of estimated prevalence of HIV amongst trans populations. So the best data that we have to date is a global meta-analysis from Boral et al., which was published in 2013. The US specific results had an estimated prevalence of 22% of HIV positivity among trans populations within the studies included. In 2008, the CDC released a study that, with a 28% estimated HIV prevalence among the populations included. And so when we're looking at that, they kind of broke it down to sort of the self-report. And so 12% of the individuals within all of the studies that were included in this meta-analysis self-reported that they knew that they were living with HIV. So what this is telling us is that there's a big discrepancy between trans individuals who know their HIV status and trans individuals who do not know their HIV status. And I'm sure, as everybody knows who's on this webinar, that Black and African American trans women bear the largest disproportionate numbers of HIV within trans communities, within all populations. That particularly Black trans women are the communities that are placed at highest risk for HIV compared to all other groups. And that's largely due to, all of the other socioeconomic factors that folks experience, transphobia and racism combined, and very frequently poverty combined. And we'll be talking about that a little bit later in the impact on people's lives. When we're thinking about trans men and HIV, there are HIV prevention opportunities for trans men. And what the research has shown is that there are very few sort of HIV prevention methods that are tailored towards trans men. And we know that trans men do engage in behaviors that could place them at risk for HIV. However, we do not see we do not see this reflected in HIV prevalence or HIV incidence data. Only 0 to 3% generally for all studies that have looked at trans men and HIV. 0 to 3% of trans men are living with HIV. Next slide, please. And so just because, particularly for trans men, just because we do not see that trans men, a significant number of trans men are living with HIV does not mean that there are not HIV prevention interventions that need to be done, particularly around PrEP, because we really have an opportunity to impact HIV before it becomes an issue within this community. And so that's a very unique opportunity that I hope that we are all responding to. This slide is just going into a little bit more detail about the findings from the global meta-analysis from Boral et al. In 2013. You can see the countries that were included here, as well as the estimated prevalence among the countries. Next slide, please. So there were 15 countries included for a total N of 11,066 trans women. The overall estimated HIV prevalence was 19.1%, and the odds ratio for being infected with HIV, for trans women being infected with HIV compared to all other adults of reproductive age, was 48.8. This is really meaning that trans women globally are bearing a very large burden of HIV. It's a very disproportionate rate of HIV that we see amongst trans women in particular on a global level as compared to all other populations. Next slide, please. So thinking about PrEP, and I'm going to really focus on PrEP because the project that I'm currently working on is a PrEP demonstration project. And there is currently still very little information about trans communities and PrEP. We find that trans women in particular have low levels of awareness of PrEP. There is currently, we're working on it, but there's no trans-specific guidance for PrEP implementation. Even within the current CDC PrEP guidance, it's really disturbingly lacking in information that would be specific to trans communities. We see very low levels of enrollment and retention in demonstration projects. This is a study done by San Francisco Department of Public Health, that trans women are rarely included in observational studies, and if they are included, rarely disaggregated, so it means that that data is rarely pulled out and analyzed separately. What we see a lot of times is, MSM and trans women within the titles or within the general description of these journal articles or of these data presentations, but then we don't see the data specific to trans populations. And then of the existing clinical trials, iPrEx is the only one with confirmed enrollment of trans women. Next slide, please. So the iPrEx study included trans women in the original trial, but did not disaggregate the data when reporting the results. Some of our researchers here from the Center of Excellence for Transgender Health, as well as Bob Grant, who was one of the main researchers for the iPrEx trials, later conducted a sub-analysis of the iPrEx data, which revealed a zero effectiveness among trans women, likely due to adherence issues. We do not think that this zero effectiveness is because PrEP, for some reason would not work amongst trans populations. It is what was found in the sub-analysis is that trans women, particularly those on hormones, were less likely to have protective drug levels than those not on hormones. And so it looks like an adherence issue. And we think that this is because none of the information, none of the interventions was specifically created or targeted to trans female communities. It was all mostly focused on men who have sex with men. And so of the trans women at iPrEx, there were 2,499 participants total in iPrEx. 14% reported that they were either identified as women, identified as trans, or reported the use of feminizing hormones. And then among the individuals who identified as trans women, there were 11 people who seroconverted in the active arm, so 11 people who seroconverted who were receiving PrEP, and 10 people who seroconverted in the placebo arm, so 10 people who were receiving the placebo, which was not PrEP. And so, again, this is what leads us to this sort of zero effectiveness level on an intervention, intention to treat basis. But again, we do not think that that is because for some reason PrEP would not work. We don't know. We are currently in the process of finding out. Next slide, please. Through some of our research that we're doing and some of the research that's been doing by some of our colleagues at other institutions. So I'm thinking through what are some of the facilitators and barriers to PrEP acceptability amongst trans women. We conducted some qualitative data collection with trans women in San Francisco, which included 3 focus groups and 9 individual interviews. Next slide, please. And so we can see here that some of the facilitators of PrEP, this is like, sometimes we do research and it's really silly because anybody who works within trans communities would be able to just know this without having to do research. And we have to be able to publish these results and be able to publish this data in order to be able to receive funding accordingly. And so facilitators are that, obtaining PrEP from a trans-informed provider, receiving PrEP education from trusted sources, and also around risk perception, perceiving that an individual is engaging in behaviors that might place them at risk for HIV. Barriers are that information about PrEP is, at this time was not disseminated via trans networks, via trusted networks of trans communities. People also have very large, very real concerns about potential interactions with hormones, and then also just general mistrust that trans communities have for medical providers due to previous experiences of stigma and discrimination, and sometimes even physical assault within medical settings. Next slide, please. And as we're waiting for the next slide to come over, just thinking through what some of the concerns are about interactions with hormones. That's something that we're looking at in our current research, but it's really an unknown right now. And so we do not believe that there would be any reason for hormones and PrEP to have an interaction that would negatively impact, a person's ability to adhere to PrEP. But it's largely an unknown. So we are currently engaging in that research, and I'll talk about it very shortly. Just looking at some of our qualitative data, around risk perception and acceptability, this participant said, if it stopped my hormone progress, I would be irate because I like to look pretty, and pretty is a soft face. And if hormones do not give me that soft face while taking a pill that's supposed to stop something that condoms do pretty just fine by themselves, that would definitely make me stop instantaneously. Next slide, please. Around lack of information via trans networks, I would love to see the stats on trans involvement with PrEP, and I would like to see it talked about a little more because trans women, just being trans women, are at risk for HIV, AIDS, and STDs. So anything that can detour that risk definitely needs to be had in broader conversations and brought to the same plateau as it has been in the gay community. Because I'm pretty sure it's talked about like it's the holy grail over in the gayborhood, but it's not really being talked about over here in Transtasia. Next slide, please. And we do see a lot of shifts around this, so that there is funding that has been available, particularly in the larger metropolitan areas, in terms of providing information through trans networks, doing community mobilization in trans networks, and how that might look. And so that was just a highlight of some of the qualitative data that we had from that study. When we think about promoting PrEP uptake amongst trans female populations, really look at identifying opportunities for disseminating information via trans networks. Talking about PrEP in the broader context of people's transition-related goals, as well as their sexual health and wellness. Really addressing misinformation and assumptions, including medical mistrust, and part of that is also training our clinicians and providers that are treating trans communities, so that, you know, that trans clinicians who are treating and providing care for trans patients are able to do so in affirming manners. And ideally, PrEP can be offered by gender affirming providers who are also providing hormones. Next slide, please. So this study really demonstrates the importance of the unique socio-cultural context of trans women's lives when considering how PrEP might be best marketed to trans women as a tool for HIV prevention. Some of the current PrEP research that's being done, there is wonderful funding that is, all of this research is underway through the California HIV/AIDS Research Program. They funded 3 sites in California to conduct PrEP demonstration projects in trans communities. So I'm going to be talking about the intervention at the UCSF Center of Excellence for Transgender Health. There's also a site at the University of California, San Diego, and the San Francisco Department of Public Health, and I'm listing their website there, the staystudy.org. They have some really great resources, visuals. It's a fantastic website. All of these 3 funded sites are running really innovative interventions in order to look at predictors of PrEP adherence amongst trans populations. Next slide, please. And all of these 3 interventions are targeted to all individuals who identify as trans or gender non-binary. And so we will have for the first time data on PrEP and trans male communities, as well as some data available on PrEP and communities that identify as gender non-binary. And there's very, very, very little information in all of the HIV prevention research literature on trans communities and HIV that focuses specifically on non-binary communities. And so our 3 sites will have the ability to do some sub-analysis of non-binary identified participants. And so trans is Trans Research Informed Communities United in Mobilization for the Prevention of HIV, because in HIV prevention, we love acronyms. And so you can see here that we have 2 sites. This is a site that we have in Sacramento for Triumph. And what we're doing is a combination of community mobilization as well as medical homes, looking at providing a variety of different types of resources to our participants. We have monthly groups that occur, community mobilization events, and PrEP champions in order to really address some of those barriers for PrEP uptake and PrEP adherence among trans populations. Next slide, please. We also have a Spanish language, predominantly Spanish language version of this intervention that is being delivered at La Clínica in Oakland. So this one we are calling Triunfo. Some of the differences between the Oakland site and the Sacramento site are that the Oakland site has a Miss Triunfo because our participants really wanted to have sort of like a pageant incorporated with this intervention. And so we have a Miss Triunfo who tomorrow is going to be competing in the Miss and Mr. Safe Latino competition that Instituto Familiar de la Raza puts on in San Francisco. It's a really exciting and it's a culturally specific way to address PrEP within trans Latinx communities. We had an event that we called the PrEP Posada in December, and Las Posadas are a very culturally specific celebration during kind of like Christmas time that we did, and we integrated PrEP information as well as performances and a meal throughout all of that. So this intervention is attempting to really shift community norms and to provide PrEP education in order to increase PrEP uptake and PrEP adherence. Next slide, please. Just finished data collection on our iPrEx study. The iPrEx study is looking at potential interactions with PrEP and hormones. And so we enrolled 48 individuals, 24 people who identified as trans male who are on masculinizing hormones, and 24 individuals who identified as trans female who are on feminizing hormones. And none of these individuals had been currently on PrEP. We administered PrEP for a period of 30 days, did daily observed therapy where our study staff watched these participants physically take PrEP through video calls, as also as weekly blood draws in order to look at the amount of PrEP in the individual blood systems, as well as the amount of hormones that individuals have. We are currently in the data analysis phase of this and hope to have this literature available soon. Next slide, please. As soon as we do have that, we will be sure to, we'll be running around everywhere presenting at conferences, but we will also be disseminating this information via webinars. We have our website and Facebook page here, and please reach out if you have any questions. Thank you so much. Next slide, please.
Thank you, Louise. Great job on that. We really do appreciate it. Now my pleasure to introduce Aryah Lester, the newest member of the NMAC family here as our new conference coordinator. She is a nationally awarded author, speaker, and educator, and is a transgender woman of color originally from New York. She founded the organization Trans Miami during her time as an expert consultant member of the Miami Comprehensive HIV Prevention Plan for the National HIV/AIDS Strategy and 12 Cities Project, and continued to work for her organization, the National Alliance of Transgender Advocates and Leaders. She has also been recognized with many awards, featured in numerous national articles, and was inducted in the most recent National Trans 100 list. Aryah, you're up. You're on. Up to bat.
Thank you. Thank you so much, Chip. And this presentation is basically a Trans 101 with hopefully some new information that you may not have received before, and having some Trans Competency 101 workshops at your organization. So first off, what is transgender? What does the term mean? Well, Merriam-Webster's dictionary defines trans as being of or relating to or being a person whose gender identity differs from the sex that you were assigned at birth. Now, under this definition, you can see that there's a lot of different categories that can fall under this, and a person having identity that falls outside of the gender binary system. The gender binary system is a system that is based culturally and systematically upon just two genders. Right now in the United States, generally, we only have male and female. So under that umbrella term, we have many different categories of gender identities that differ from societal gender norms, especially here in the United States. Now, this umbrella is actually more of a governmental term than a term that the communities have adopted upon their own. So there are a lot of terms that fall under the transgender umbrella, which we would get into. But in the beginning, we're going to show the difference between trans and cisgender. You may have heard the term cisgender pretty much a lot lately if you are involved with anything in the LGBT community. And cisgender is basically the opposite of transgender. And it means someone whose identity corresponds with the sex that they were assigned at birth. Here you see a chart of different pronouns that a person can use in order to talk to a trans or gender nonconforming person. Now, we want to be careful about using the term preferred pronouns because for trans people and for many people, these are their actual pronouns. They may have been given different pronouns that correlate to their sex at birth. However, their actual pronouns could be a combination of any of these pronouns that you see here in the chart. The basic general ones are he, she, his, and they, and then also thee and they are also ones that are currently being used as well. And you just might find in your work that you come upon other pronouns outside of the 4 or 5 that we are most familiar with. Now, another issue is microaggressions. Microaggressions is something that can occur through a trans person's day-to-day life. It can come from a coworker, a family member, a friend. And these are some examples of microaggressions because although we know what microaggressions are, especially when they may be racially motivated, here are some microaggressions that are gender motivated. I'll read them out just in case you have problems with the screen. One is, did you have the surgery? Surgery questions in of themselves is something that can be very disrespectful to a trans person, even if that trans person is your friend, because any questions on surgery relate to what's between that person's legs. And unless you have a relationship to where you're fine with talking about your private parts with each other, then this is something that we want to stay away from. The second one, you're so beautiful for a trans girl. The third one, which Chief Milan, is, wow, I would have never known you used to be a girl. Well, you understand what it's like to be a woman. This is directed to a trans masculine identified person in the picture. So when are you really going to transition? This is held by Jacob, who's a gender nonconforming person. Are hormones going to change your voice too? That's just straight shading, in my opinion, and really doesn't have to do with microaggressions. But these are examples of some things that may seem innocent, but we really need to think through before we approach any trans person. Now, we know that it's best to ask questions if you are unsure about something, but be sure that your questions aren't rooted into microaggressions. Now, I just wanted to get just a little bit into sequential hermaphroditism, or where you see some characteristics of gender nonconformity when it comes to the gender binary system in nature. One example is the ribbon eel. The ribbon eel can change its sex from birth from male and black to this beautiful rainbow-colored eel when it develops female sexual organs and changes sex. Another example is the clownfish. The clownfish they carry around their little lives in the ocean in schools, and those schools are kind of ran by an alpha female. So she's the biggest one, she's the one in charge. If something was to happen to the alpha female, be it by predation, disease, or anything that can take away the life of the alpha, then the male beta, which is the partner to the alpha female, will change its gender and become the alpha female. And we also see the same thing happening in reef fish, the other way around. And another example that you can always research are the islands of Botswana. There are a group of lionesses in Botswana who actually have grown manes. So they display physical characteristics of male lions. They're bigger than the other female lionesses, and also their behaviors are like the male lions in which they patrol and protect the territories as well. Here are some terms that you may heard or have heard in the past when it comes to relating to transgender individuals. Transsexual is a term that was mostly used in the 90s and early 2000s, and that term is specifically towards, under the transgender umbrella, someone who is traveling or transitioning from one end of the gender spectrum to the other by means of medical or surgical interventions. Meaning that a person does not have to be going through any type of surgical or medical intervention to be transgender. This is more of a specific characteristic of someone who identifies as transsexual. Femme queen is something that you may have heard, especially with the popular show Pose that's going on right now, and it is a term that's used in the ballroom community. We also have pre and post-op, which is going towards that territory of, asking what's between a person's legs. It's something that has been used internally within the trans community, but we want to kind of stay away from those types of terms now, because we don't want to just bring any attention to a gender being kind of related to sex, when gender in of itself is an identity that's separate than your physicality. Ladyboy is something that sounds like a bad word, but it's used in some South Asian communities to where they self-identify as that. You may find some of these other terms, such as hydra, also when you're dealing with other communities outside of America or outside of your traditional American communities. Drag queen and drag king. A drag queen and king is not necessarily a trans person. When we get into some cofactors of mental health, you can find some compulsive cross-dressing, which could be a result of a person that actually does identify as trans, and their only means of expressing this may be through drag. However, for the most part, a drag queen or a drag queen is someone who dons on a persona for entertainment or work purposes. Bardage is a Native American term that we don't want to use anymore, and so I put these two terms here, bardage and transvestite, are two terms also that you want to stay away from. They were used in the past. However, the Native American term is now two-spirited, and we just have removed transvestite pretty much from our vocabulary, unless it has to do with the Rocky Horror Picture Show. All right, gender diversity in human nature and human history, that is. There's a lot of human history and a lot of trans individuals that have dotted throughout our centuries. One is the Hydras. There's a good story about Bahatra Mata where he told his devotees in a village to not wait for him at the gates when he went off on his journey, and for every man and woman to go back into the town and he'll be back eventually. So he left, he was gone for years, he came back, and there was trans people right there. There were gender non-conforming people that waited for years at the gates because he gave the rule, all men and women go back, and they were like, Lord Bahatra Mata, we are neither men nor women, so we waited for your return to come back. And two-spirit individuals in Native American cultures are individuals whose bodies house both a female and a male spirit, and in doing so, these individuals were deemed more wise and having more knowledge than your average person. So, for example, when you needed your spirit name after your birth, you would go to a two-spirited person in order to receive that. And here we're going to go briefly through a few more examples, and I'll do this real quick because I want to save time for Q&A. Pharaoh Hatshepsut was someone who was born female and used a false beard and ruled as a male in ancient Egypt. We have Roman Emperor Elagabalus, who sanctioned the first research into sexual reassignment surgery back in the early beginnings of the Roman Empire. We have a diplomat and spy, the Chevalier d'Eon, who was adorned to dress as a woman as far as espionage, but then after that, I actually took on that persona and personality for the rest of her days. And then Karl Heinrich Ulrich, that is somebody that you should research for anything to do with LGBT, because he coined most of the phrases that we use today, not only for the trans community, but for gay and lesbian communities. This example is an example of a trans person, Janet Mock, at the top, who is also a writer of Pose, was a editor of Marie Claire. And then we have an example of someone else who seems even more feminized than Janet Mock, but who is not a transgender individual. This is just showing an example that you cannot assume a person's gender identity by looks. You can see somebody that is RuPaul and assume that this is somebody who is transitioning or has transitioned and it identifies as a trans woman. However, RuPaul is simply a gay man who enjoys dressing that way. Janet Mock is someone who self-identifies as a trans woman. So these are points to make out that you cannot go upon looks alone in a person's identity, and you have to ask how a person identifies and what pronouns they would like to use. Here are some more examples: Laverne Potts, Chaz Bono, who's the son of Cher. Here are some trans issues when it comes to case management and when it comes to addressing HIV and interventions or support groups at your agencies. We performed a listening tour in South Florida back in 2012, and these were some of the issues that the trans community came up with: a lack of cultural competency at programs and agencies that are offering services for trans people, not understanding the difference between gender identity versus sexual preference. Even though the government has lumped us all together into the balloon of LGBT, the first three letters all have to do with sexual orientation, and the trans portion has nothing to do with sexual preference at all. A lack of access to jobs and training, and lack of community involvement, which was pointed on in Luis's slides earlier. There was a lack of empowerment for managed HIV care. There's a need of prevention and education at an early age for all public individuals, addressing stigma and ostracism, and being that defined as a population separate from the MSM, which Luis also pointed out. And this is a point that has to do with data specifically, because we have a lack of data because it has always been conflated with MSM communities. Here are some brief mental health issues such as depression, suicide, self-harming behavior, thought and personality disorders. These are all things that can lead to or can coexist with high HIV rates of infection or susceptibility when it comes to behavioral issues as well. Trans community assistance. One thing that is needed hasn't popped up on your screen yet, but as soon as it does, mentoring and training is needed for all employees. If you want to address the training, one good thing to do is online dating, having a presence where the community actually is located at, having educational materials that are appropriate for people who have sex with or are partners with transgender individuals, which is something that is lacking, and training for healthcare providers and knowing how to actually approach a transgender patient, how to have your programs to be sensitive and welcome. We can skip this slide as well. And here is some reference material. And I think that that is it for me, and we're going to leave a little bit of time for some Q&A. I see there's some questions in the queue.
Thank you, Aryah. I know, just a quick housekeeping point, several folks have asked about the reference pages for both presentations. The video of this webinar will be posted on the NMAC YouTube channel later today or early tomorrow, so you'll be able to find the reference pages in that video. and I sent out a link through the chat box for that, so look for it there either later today or early tomorrow morning. So now we're going to open up for Q&A, and looking at we have a few questions in the chat box. Let me scroll back real quickly and see what we have. I'm actually going to do, instead of, I see Alexa Rodriguez, I see you've had several questions. What I'm going to do is I'm going to unmute Luis's line, and then I'm going to unmute yours. And you can go ahead and ask your questions to Luis and Aryah. And Alexa, you should be unmuted. Can you hear us?
Alexa?
Can you hear us, Alexa? I'm sorry, Alexa, we can't, if you're speaking, we can't hear you. All right, let's see if we can go through her questions from, just from the chat box. And Alexa, if you enter in the chat box anything we get wrong, let us know. Let me scroll back really quickly. So I think we have a few questions from Alexa and some others about the lack of information regarding effective interaction of hormones with PrEP. Luis, do I want to direct that question to you? Do hormones affect uptake and level of PrEP in the person's body tissue, or is it specific to tissue? An example, is it specific, how does it interact with anal and vaginal tissue?
So great questions. We are currently, as I discussed during the iPrEx study, we are currently conducting the first pharmacokinetic analysis of PrEP and hormones. And so we will have data very, very soon to say whether or not, and if there is, what the directionality would be between any interactions between PrEP and hormones. So we do not yet have that data. What I can tell you is, there's not really a biological reason that would exist within any of the literature looking at potential interactions between PrEP and hormones, particularly looking at the use of hormones among cis women or non-trans women who are taking PrEP, who are also taking hormones, that we don't see that interaction. But we do not yet know. We do not think that there would be. We will know very soon. We're just sort of waiting for our data to be analyzed in the labs that they are being sent to, and then we will be able to state from the sample that we had enrolled in our iPrEx sub-study whether or not that is true. In terms of the different types of, I saw that there was a question around the different types of body tissues. And PrEP effectiveness, we do not know, and we will not know based on the current studies that have been funded about the amount of time for PrEP to be effective within a neovagina, or for PrEP to be effective within a constructed penis for trans men, or after a trans man who's had phalloplasty. So we just don't know, and we also generally do not know sort of that HIV prevention information. Like we don't know that for HIV in general or other STIs. This is an area of research that is desperately needed to look and see what are the biological risks associated with for trans people who have had genital reconstruction surgery or gender affirming surgery on their genitals. It's something that would be a little bit difficult to do because different types of tissues are used based on the procedures that are done for the individual. And so that is not information that we have. So generally the recommendation would be, to follow, the longest amount of time that would be available, but we will be able to do some sub-analysis in our overall study across all of the 3 funded sites in California, looking at individuals who have had, different types of surgeries on their genitals, and be able to look at PrEP effectiveness, PrEP adherence among those participants, and also look and see the number of sexual encounters that they've had with other partners, according to the data that they've reported. So we will be able to do some analysis on that. That data, that literature just currently does not exist. It is forthcoming.
Great, thank you, Louise. One of the questions come up, and I think this is a question for Aryah. What's meant by online dating education and presence?
That's directed towards outreach, and trans individuals have said that one of the best ways to outreach the most vulnerable of the trans community, specifically trans women of color that have to engage in survival sex work, would be online dating apps and sites, and having ads there that kind of gives some basic education or give some info as far as where to get resources and services for PrEP, for HIV management, and also outreach for any of your programming. A lot of programs around the country have been really successful in contacting individuals through the dating sites, whereas otherwise they are not able to contact that community.
Great, thank you. Looks like we have a follow-up question to that, Aryah. Are there any specific dating sites?
Wow, what is this question for? I mean, there's a whole slew of new sites now that, Craigslist and Backpage were kind of shut down for trans community and people that have to subsist upon those resources for their survival. I know that Plenty of Fish, I believe it's called, Plenty of Fish, POF, I think is what they call it. The other ones, such as Grindr, have expanded their roster to include trans as an identity on there, and some other ones. A quick research or identifying a trans person that works in the community in your area can let you know what those sites are.
Great, thank you, Aryah. We still have a few minutes left. Any additional questions? You can please enter them into the chat function. And we still have a few minutes left here if anybody has additional questions.
I know that there was another question all the way up top. Louise, is it proven that PrEP can interact negatively with Truvada?
And Louise, did you?
I'm sorry. Can you repeat that question? That my unmute audio came up right as the question was being asked.
Yes, the question under the chat is it proven that PrEP interacts negatively with Truvada?
Oh, okay. That person probably meant to ask about hormones and PrEP. So I'm sorry, I did not define PrEP for everybody during my presentation. So PrEP is pre-exposure prophylaxis. The only medication that is currently approved in the United States for use for HIV prevention every day is Truvada. So Truvada currently right now is PrEP. There are clinical trials that are underway globally looking at other types of other types of medication that can be used for prevention purposes, but PrEP equals Truvada currently. And so we do not know, again, we do not yet have the data around potential interactions of PrEP or Truvada with hormones. We are conducting that research. We will have that information probably within the next few years. The data collection is currently underway. We are currently enrolling participants across all of the sites that have been funded in California. And we will have that answer for folks very soon. But it is still an unknown. And so, there is this distrust of trans participants and trans people and trans communities of PrEP, concerns about hormone use, and those are very valid concerns. We do not think, and there are no biological indicators or reasons why there would be negative interactions of PrEP and hormones. What may occur, what we do see with some HIV treatments is that that hormone levels may have to be adjusted based on different HIV care or antiretroviral therapy that is prescribed for individuals living with HIV. The same may be true of Truvada, and so the best advice that we can give to individuals is to work with their clinicians, to have their hormone therapy provided by a clinician who has trans competency, and to have their hormones monitored according to the current clinical guidelines, and to have their hormones monitored as well as their PrEP monitored.
All right. Thank you, Louise. We have one other question here. Before we get to that, a quick housekeeping mention. Please fill out the evaluation form at the end of the webinar. It's very vital for us as we are continuing to improve this series, and so your feedback is greatly appreciated. Louise, another question coming in, I think, is for you. What can you tell us about the recent trends of other STIs, especially syphilis, among transgender individuals?
I'm not sure if that question, there's this misconception that a lot of people have that, because PrEP is now available as an HIV prevention method, which it does a fantastic job of preventing HIV, a lot of people think that there is a correlation within a rise of STIs. And that's not necessarily true. What is occurring is that because when individuals are on PrEP, they're getting tested for HIV and other STIs on a more regular basis. And so what's occurring is that, public health systems are now doing a better job of capturing, the sort of true occurrence of different types of STIs that might be happening within certain communities. And additionally, with trans individuals, we have more HIV prevention clinics as well as STI testing clinics and STI sites that are increasing their transgender cultural competency and their capacity to serve trans individuals. So what we are likely seeing, if we ever talk about sort of like a rise in STIs amongst trans populations, it's likely that more trans people are being tested than they were before. Remember when I was talking about that 2008 meta-analysis that the CDC published, where 12% of all of the respondents in all of the studies that were included self-reported living with HIV, but we saw an estimated HIV prevalence of 28%. What that is telling us from that 2008 study is that the trans women within all of those studies were not getting tested regularly. They did not know their status. And so in thinking about, sort of this rise in STIs that might be occurring, it might all just be a factor of we are finally getting clinicians who are competent and who are providing HIV and STI testing to trans people without any stigma, without any, in culturally competent ways.
Thanks, Louise. We're about out of time. Just a reminder to everyone to please fill out the evaluation form. Mark your calendars. Our next webinar will be on July 11th, where we'll be walking folks through the scholarship process for the HIV Biomedical Summit in December. We also have additional webinars coming up. So check on our website, nmac.org/webinars, to see the latest schedule and latest calendar for webinars that will be coming up. We have 2 to 3 more of these community spotlight webinars coming this year, so please watch for those. If there are no more questions, thank you all so much for attending. Again, this video will be online later today or early tomorrow on NMAC's YouTube channel. Thank you so much and have a good rest of your day.